For the first time in over 20 years, the American Medical Association has changed the way that outpatient healthcare providers document and bill patient visits. The goal of this presentation is to help you understand the nuances and intricacies associated with these changes. My name is Dr. Jason Leonard, and I'm board certified in both family medicine and in obesity medicine. I'd like to start by doing a disclaimer that I'm not a certified biller or coder, but simply an experienced physician who has spent countless hours studying and understanding these changes so that I can help educate you on them. These changes went into effect on January 1st of 2021 and apply to outpatient services only. So as I stated a minute ago, these are the first changes to the way that healthcare providers document E&M codes since 1997. And really, the goal of this change by the American Medical Association was to ease provider documentation. So let's talk about some of these changes that can hopefully help ease our documentation burden. So the first change is that the history and examination sections have been eliminated when it comes to choosing the E&M level of service for that outpatient encounter. Also, total time alone may now be used to bill an E&M level, and that includes both time with the patient and time spent both before and after the patient in charting and preparation. Finally, certain codes have been eliminated and simplified, and the goal of this presentation is to go over these changes in more detail. Probably the most significant change regards the history and physical exam section. This section is still required, but documentation of these components is no longer counted when selecting E&M codes for outpatient visits. So this does include the review of systems, the past family, social, and medical history, as well as the physical exam. And the new guidelines simply read that you must include a medically appropriate history and/or exam when it's performed. Now, from a medical and legal standpoint, it's still important that we document the details of that encounter accurately. But the burden of making sure that everything completely lines up and unnecessarily spending time having the review of systems match the history and the exam and the medical decision-making components no longer exists. Speaking of medical decision-making, really that's what it's all about at this point. So again, history and physical exam have been removed from the required elements when you select the level of service you provide. So before 2021, we had to factor in three components, and they were history, exam, and medical decision-making. And now in 2021 and beyond, it's either medical decision-making or total time. One thing you're going to note from this chart here is that the criteria for choosing the level of service has really been simplified. As a matter of fact, the rules that apply to new patients also apply to established patients and vice versa. Before 2021, for outpatient visits, the criteria for a level 3 or level 4 for a new patient were very different than the criteria for selecting a level 3 and level 4 for an established patient. That no longer is the case. In addition, the code 99201 has been eliminated. 99211 was already not being used for outpatient services when seen by a healthcare provider, but now additionally 99201 has been eliminated. So let's really focus on medical decision-making, and that's what the bulk of this presentation is going to highlight. And the goal is to understand these new rules that were implemented this year. As in years past, there are three key elements to medical decision-making, and these apply to both new patient and established patient visit codes. And they are three components, which are the problems, and that means the number and complexity of problems addressed, the data, which is the amount and complexity of data that's reviewed and analyzed during that visit, and then the risk of complications and or morbidity or mortality of the management of that patient. Now, as we'll see later in this presentation, in order to select a level of service, two of these three elements of medical decision-making must be met or exceeded. Now, the definitions and the documentation requirements have changed, and while they may seem similar on the surface, there are certainly some little nuances that are really important that you understand if you are seeing patients in the outpatient setting. So the first thing we're going to talk about is the number and complexity of problems addressed, and this replaces the number of diagnoses or management options that we used prior to 2021. So let's see a little bit more about what the AMA has to say about this first component. So the real key distinction here is the number of complexity of problems addressed at that encounter. So obviously, multiple new or established conditions can be addressed at the same time, and they may affect medical decision making. But the AMA throws some nuances on here that I need to review with you. First, a problem is addressed when it is evaluated or treated at that encounter, and that may or may not include further testing or a decision that was discussed but not elected to be undertaken, such as hospitalization. Very clearly, though, the AMA states that notation in that record that another professional is managing the problem without additional assessment or care coordination does not qualify as being addressed. A great example of this is a patient with rheumatoid arthritis who is being managed by a rheumatologist. Simply noting that the patient has rheumatoid arthritis and they will continue to follow up with their specialist, or that it's being managed by a specialist, but without actually being addressed specifically at that visit, does not count as a problem that is addressed when factoring in the level of service of that visit. Additionally, placing a referral without an evaluation is not counted as a problem. If a patient comes in with established psoriasis and you're simply referring them to their dermatologist, or a patient comes in with hearing loss and says, hey, I want a referral to an audiologist, but it's nothing that you actively manage at that visit, then you cannot count that toward the number and complexity of problems addressed when it comes to choosing the level of service. Also, sometimes symptoms can cluster around a diagnosis, and each symptom is not necessarily a unique condition. And a great example of this is a patient with a fever, body aches, and a cough that you end up diagnosing with influenza. Certainly, the influenza counts as a problem that's addressed at the encounter, but the symptoms are not considered unique conditions. Following this, comorbidities and underlying diseases in and of themselves are not considered in selecting an E&M service. Just because a problem is mentioned in a problem list does not mean we assign a diagnosis code, because if we do not address it specifically, and if it does not factor into the decision making during that specific encounter, it should not be counted when determining the level of service. Underlying conditions not only must be addressed, but again, they must increase the amount of data reviewed or the risk in that patient management to count when deciding the level of service of that visit. Sometimes the final diagnosis, though, is something that's really benign, and the final diagnosis, therefore, does not determine the full complexity or risk. Sometimes you need to do an extensive evaluation for a condition and realize that it's benign and does not represent something that's highly morbid, but it took a little while to get to that. And so, therefore, you don't want to just base it on the final diagnosis, but the entire complexity of risk and the number of issues you manage during that visit regarding that condition. Along these lines, multiple problems of lower severity may aggregate to create a higher risk due to interaction of these things, such as a patient that has hypertension with chronic kidney disease and heart disease. Now, the AMA has given several definitions, and I want to review each one of these so that you can understand what types of problems fall into what categories when determining the appropriate level of service. The first thing I'm going to talk about is a self-limited or minor problem. Now, the AMA defines this as a problem that runs a definitive and prescribed course, is transient in nature, and importantly, not likely to permanently alter health status. A cold, an insect bite, or some kind of a fungal rash like tinea corporis are examples given for this. This is contrasted to an acute, uncomplicated illness or injury. And this is a recent or new short-term problem with a low risk of morbidity. Now, on the previous example, there was really no risk of morbidity, and in this case, we have a low risk of morbidity. But this is still a problem that is usually self-limited or minor, but is not resolving with a definitive prescribed course. But again, there's little or no risk of mortality with treatment, and a full recovery without any functional impairment is expected. A great example of this is a urinary tract infection, something with standard treatment you would expect a full recovery with no functional impairment. Of course, if not treated, that can progress to pyelonephritis or something worse. Other examples provided by the AMA include allergic rhinitis or a simple sprain. The next level up from this would be an acute illness with systemic symptoms. And this is an illness that causes systemic symptoms and has a high risk of morbidity without treatment. So again, general symptoms such as fever, body aches, fatigues, and a minor illness are not considered here as an acute illness with systemic symptoms. Examples of an acute illness with a systemic symptom would be pyelonephritis. This is obviously a urinary tract infection that you have symptoms that this is spreading to the kidneys and beyond. Pneumonitis and colitis are also given as examples by the AMA. An acute complicated injury, unlike an acute uncomplicated injury or illness. An acute complicated injury is an injury that requires treatment, and that includes evaluation of body systems that are not directly part of the injured organ, or the injury is extensive, or the treatment options are multiple, or is associated with the risk of morbidity. A great example of this would be a concussion or some other kind of head injury with a brief loss of consciousness. Now, an undiagnosed new problem with an uncertain prognosis is a new terminology for this year. And this is specifically defined as a problem that represents a condition that's likely to result in a high risk of morbidity without treatment. And really the key thing is here that this should result in a high risk of morbidity if not treated. This really differentiates this from an undiagnosed problem that may have a very low risk of morbidity. A great example of this is a breast lump or a neck mass or something like that, that while it certainly could be benign, may in fact be something much more serious like cancer. Now, transitioning to chronic illnesses that are dealt with on a regular basis, this is an area that many providers are going to need to really understand, because this is an area where many chronic conditions fall under. So a stable chronic illness is defined as a problem with an expected duration of at least 1 year or until the death of a patient. Now, what's defined as stable is based on the individual patient. For example, what a stable blood pressure reading for a 75-year-old may be different than a stable blood pressure reading for a 25-year-old. Now, a patient that is not at their treatment goal is not stable, even if the condition is unchanged and there is no short-term threat to life or function. Very, very important distinction for this. Something that is not well controlled, even if it's not changing, is not a stable chronic illness. A great example of this is a patient with persistently poorly controlled blood pressure for whom better control is a goal. This is not a stable patient, even if the blood pressure is not changing, even if the patient is asymptomatic. One of the key things to consider with this definition is that the risk of morbidity without treatment is significant. It may be a long-term risk of morbidity, but if untreated, the risk is significant. I'll continue with the use of high blood pressure, which is where if you do not treat the blood pressure, that may not cause an immediate risk to life, but down the road certainly can increase risk of renal disease, cardiac disease, and cerebrovascular disease. Other examples include diabetes, cataracts, BPH. Now, chronic illness with exacerbation, progression, or side effects of treatment, this would include a condition that is not at goal, but stable, meaning that it's a blood pressure that is not changing, but it's not well controlled. This is a patient you've seen in the office for follow-up. Their blood pressure was 160 over 102. You see them back for the next visit. Their blood pressure is very similar. It hasn't changed. The patient's asymptomatic, but still not at goal. That falls into this as well. But the definition given by the AMA is a chronic illness that is acutely worsening, poorly controlled, or progressing with an intent to control progression and require additional care or additional attention to treatment for side effects, but does not require consideration for hospitalization. Examples of this, again, as we just mentioned, include uncontrolled hypertension. Additionally, worsening renal disease or advancing dementia would fall into this category as well. Now, the next step up from this is a chronic illness with a severe exacerbation, progression, or side effects of treatment. And this is something that poses significant risk to morbidity and may require a hospital level of care. Now, let me emphasize, may require is not the same as will require and will be admitted to the hospital. So even if you discuss hospitalization because the condition is so severe, but either you or the caregiver or the patient elects not to undergo a hospitalization, that would still count for this definition of a chronic illness with a severe exacerbation, progression, or side effect of treatment. A COPD exacerbation or a hypertensive emergency would be great examples that fall into this category. Now, an acute or chronic illness or injury that poses a threat to life or bodily function is an acute illness with systemic symptoms, or an acute complicated injury, or a chronic illness or injury with an exacerbation and or progression that does pose an immediate threat to bodily function or life without treatment. Some great examples of this include a myocardial infarction, pulmonary embolism, severe respiratory distress, progressive severe rheumatoid arthritis, or even a psychiatric illness where the patient is a threat to themselves or others. As you can see in this slide, the AMA provides some other examples as well. Okay, now that we've addressed the number and complexity of problems addressed at the patient encounter, let's move on to item number 2, which is the amount or complexity of data to be reviewed and analyzed. And this replaces the amount and complexity of data to be reviewed. And the key addition here was analyzed. And let's go over the definitions here. Again, this change on the surface seems very superficial, but there really are some definitions which need to be understood to make sure that you are coding and properly documenting the level of service. Now, regarding the amount and or complexity of data to be reviewed and analyzed, this is really divided into 3 categories. The first category takes into account all the tests, documents, orders, or independent historians that were utilized during that day for that encounter. Each unique test, order, or document can be counted to meet a threshold number, and we'll go into that in a little bit more detail in a future slide. The second component is the independent interpretation of tests that are not separately reported. And when you read the word reported, I more want you to think about the word billed. This is the independent interpretation of tests that are not separately billed. And finally, the discussion of management or test interpretation with an external physician or other qualified healthcare professional or appropriate source. And we're going to go into those definitions in just a little bit. So again, let's talk about the first of the 3 components, which are test, orders, documents, independent historians. So number 1, this includes the review of prior external documents from each unique source, the review of results of each unique test, and the ordering of each unique test. Also in this group is the assessment requiring an independent historian or historians. Now, let's talk a little bit more about the reviewing of external documents from each unique source. The AMA defines external as records, communication, and test from an external physician, someone not affiliated with your practice, or another qualified health professional, as well as an external facility or healthcare organization. An external professional cannot be in the same group practice, or if they are in the same group practice, is a different specialty or subspecialty. And again, this can also be a facility or a provider such as a hospital, nursing home, or home health care agency. Each unique source, not each document from that source, but each unique source counts as 1 point. If you're reviewing a patient for a hospital follow-up and you review the admission history and physical, maybe an echo that was done during that visit, blood work that was done during that hospital stay, and consultant notes as well as a discharge summary, that is a unique source and would only count as 1 point. If you have a patient that comes into your office and you're reviewing a referral from a rheumatologist, and then you're also reviewing a referral from a pulmonologist, each one of those counts as a unique source because they're from different practices. When it comes to reviewing the result of each unique test or the ordering of each unique test, it's important to understand what that means. Tests can be imaging tests, laboratory tests, psychometric tests, or physiologic data. That includes laboratory tests that are in the 80,000 series of CPT codes. That includes diagnosis tests in the 70,000 series of CPT codes, as well as medical tests in the 90,000 series of CPT codes. And there really is a differentiation between single or multiple tests that's defined by each CPT coding set. Lab tests with their own CPT codes are considered unique tests. For example, a monospot and a quick strep each have their own CPT codes, and therefore, if ordered, would be 2 unique tests and would be counted twice. Additionally, a liver function panel would be 1 unique test, and a urinalysis would be another unique test. Now, as I just mentioned, a liver function panel would be a unique test. A panel of laboratory tests, because it has 1 single CPT code, is considered a single unique test. For example, a basic metabolic panel, which is CPT code 80047, is a single test, even though that includes creatinine, electrolytes, and a glucose. So you can get points for ordering each unique test, and that can make those points add up very quickly if you're doing a complex workup on a patient. There's also separate counting for reviewing each unique test. So if you have a patient and you come in and you order a CBC and a Chem 7 based on reviewing prior test, you would count the points for reviewing the test that you reviewed as well as for ordering the test that you were ordering during that day. Again, when you're doing a big workup on a patient, This is a very easy way to get a number of points in this category. Now, let's talk about assessments that require an independent historian. So an individual who provides a history in addition to what the patient provides, because the patient is unable to provide a complete or reliable history, or because you need some kind of confirmatory history, can count toward the amount and complexity of data that's reviewed and analyzed during that visit. This happens all the time. Very often a spouse provides additional history that the husband may not be forthcoming about, or a parent is your primary source of history due to the child's developmental stage, or a guardian or child provides a history for a patient that has dementia. These are all things that increase the complexity and the amount of data that you need to take in for that visit to determine the level of service. When that history is important and when you judge it to be medically necessary, it's very important you document that so that you can count that toward the level of service. So in cases where there is poor communication, there's conflict, and multiple historians are needed, this requirement is met. And this is something that I feel, especially in primary care, but probably across all specialties, is very frequent and very underdocumented. Now let's talk about independent interpretation of tests not separately reported. And again, I really want you, when you read the word reported for this, to consider billed. So the actual performance or interpretation of diagnostic tests during a patient encounter are not included in determining that level of service when it's billed separately. If a test is independently interpreted in order to manage the patient, but is not separately billed, then it can be part of the medical decision making. But whether or not it's separately reported, aka billed, is really the key distinction here. Now, the interpretation of a test needs to meet certain criteria, and that means there needs to be a CPT code for that, and it needs to be a test where an interpretation is customary. Now, the form of interpretation should be documented, but it does not always have to conform to the usual standards for a complete report of that test. Let's review some examples about this. So one example would be a surgeon who reviews a mammogram and compares it to a mammogram from the year prior. The surgeon certainly did not bill for either image, but he did have to review those images, and he'll probably make a notation such as mammogram from 2020 normal, mammogram 2021 has a lesion. This is a test, the mammogram, with a CPT code, who the surgeon is making a notation about or some kind of report about that does not need to be as complete as a full mammogram report, and at which the amount or the complexity of the data reviewed and analyzed during that visit certainly increases the complexity of that patient encounter. That's a great example of something that would increase the level of service for that patient encounter that day and that could be billed for. Another example would be an orthopedist that reviews an MRI that was interpreted or billed by a radiologist. Again, a separate report is not required, but the clinician should note their interpretation of the tracing or image in order to count this for this level of service. Further clarifying this, that if the healthcare practitioner is billing for the service, it may not be counted as part of the data in determining the level of medical decision making. This also applies to things that have previously been billed for. Very, very important that you are not double dipping. Now, let's talk about independent interpretation of tests not reviewed separately with some more examples. I gave some examples that are really applicable to specialists, but now I want to give an example of a primary care circumstance. So a patient is seen in an urgent care center. They come in with respiratory symptoms, and that physician orders a chest x-ray and provides an interpretation for the chest x-ray. That physician then writes a separate report interpreting the results, and then he or she bills globally for the interpretation of that x-ray, whether it's with a modifier or globally. And the distinction here is that if the professional component is being billed by that provider may not include the review of that image as part of the determination of the amount of data to be reviewed. That provider is already being paid for the interpretation and then therefore may not count that reviewing as data complexity. On the flip side, that same patient is seen in follow-up by their primary care provider 3 days later, and that provider pulls up the image and looks at the chest x-ray. That provider is not billing for the interpretation of the x-ray. That provider may include an independent visualization of the x-ray in the notation for that encounter and can utilize that x-ray in determining the amount of data for that regarding medical decision making. That's a perfect example of something that would count to increase the complexity of that encounter and that you would use to potentially increase the level of service you're billing for. Now, the final component here is the discussion of management or test interpretation. So again, this gets back to those words external. This is the discussion of management or a test interpretation with an external physician or other qualified healthcare professional or an appropriate source that is not separately billed. Again, an external professional cannot be in the same group practice, or if they are in the same group practice, is a different specialty or subspecialty. This can also include a facility or provider such as a nursing home, a hospital, or home health agency. Now here they introduce the term appropriate source. And an appropriate source is a professional who is not a healthcare professional but may be involved in the management of that patient. An example of this would be an attorney or a parole officer, maybe a case manager or a teacher. This does not include discussion with family members or informal caregivers though. So make sure you understand the definition of external and make sure you understand the definition of what an appropriate source is. This wraps up the amount and or complexity of data to be reviewed and analyzed, and we're now going to switch to the third component of this, which is the risk of complexity and or morbidity or mortality of patient management. And this replaces the risk of complications, morbidity, and mortality from 2020 and earlier. When we are talking about the risk for that patient visit, that includes the risk of complications, the morbidity and or mortality of the management decisions made at that specific visit that is associated with that specific patient's problems, that also include the diagnostic procedures and or treatments done during that visit. And again, for the purposes of medical decision making, the AMA really puts this on the provider to understand that this is based on the consequences of the problems addressed at that encounter when appropriately treated. This does not count for non-compliant patients. It needs to be when appropriately treated. Now, risk can also include medical decision making related to the need to either initiate or forego further testing, such as hospitalization, surgery, etc. This includes options that may be selected, but also options that may be discussed and not selected after shared medical decision making with the patient and or their caregivers. I've used this example a lot, but let me use this one more time. For example, a decision about a hospitalization can include consideration of alternative levels of care. This can include a psychiatric patient who may have enough support at home or in the outpatient setting, and therefore you decide not to hospitalize a patient with advanced dementia or potentially with suicidal thoughts that generally otherwise would warrant inpatient care. The definitions of risk are based on the usual behavior and thought processes of a qualified healthcare professional in the same specialty, and trained clinicians can apply common language such as high, medium, low, or minimal risk, but do not need to provide quantification of these, even though quantification may be provided when evidence-based medicine has established probabilities. What the AMA is saying by this is that it's up to you as a healthcare provider to determine what is a high level of risk, medium level of risk, low level risk, or minimal risk within the guidelines that they set forth. And we're going to go over that in just a minute. But they really leave this up to you as a healthcare provider with the caveat that it should be based on the usual behavior and thought processes of a similar healthcare professional in the same specialty. So there really are 4 levels of risk that the AMA has specified. And just as noted a moment ago, these are minimal, low, moderate, and high. And again, the clinicians determine the risk and do not necessarily need to explain their definitions of risk. And that's a good thing because in some of these, the AMA does not provide a lot of guidance. So let's go over what the AMA considers minimal, low, moderate, and high levels of risk. The first is minimal risk, and this would really correspond to a level 2 visit, both a 99202 and a 99212. And the CPT released by the AMA gives no examples. What I've read and what I've studied in other articles is that if there's really no chance of any morbidity or mortality with this patient, this would be considered minimal risk, especially if this is a patient who you are really not undergoing any workup. Maybe you're simply just reassuring them about their condition. Now, a low level of risk corresponds to a level 3 visit, both a 99203 and a 99213. And yet again, the CPT from the AMA gave no examples. But again, this might be a patient who needs to pick up medications over the counter, or who has a low risk of morbidity or mortality without treatment, but would typically get better with minimal care. Finally, when it comes to moderate risk, and again, this corresponds to a level 4 visit, either 99204 or 99214, we do have some examples. So examples provided by the AMA and the CPT are prescription drug management. Now, this is a really big one. Whether you're reconciling medications, you're stopping medicines, you're prescribing new medications, you're doing prescription drug management. And this falls into the majority of patients that I see in my clinical practice, and I assume that would fall into the majority of patients that you see for your clinical practice. Now, simply prescribing a medication or reviewing and reconciling medications or stopping certain medications alone does not mean the patient's on a level 4 visit. There are other things that need to be considered. But when you're considering the risk component of the medical decision making, prescription drug management falls into the moderate risk. Other examples provided by the CPT include decisions regarding minor surgery in a patient with identified risks, as well as decisions regarding elective major surgery without identified risks. The final example provided by the CPT are diagnoses or treatments significantly limited by social determinants of health. Now, social determinants of health is a new definition this year, and let's talk about that a little bit more. Social determinants of health are defined as economic and or social conditions that influence the health of people and communities. Examples of this include food or housing insecurity. Now, a clinician, for example, may indicate that the patient is living in a shelter and doesn't have access to a kitchen to follow a heart-healthy diet. That would increase the level of risk for that patient. Another example might be a homeless person who has a minor skin tear, the type of problem that normally would not qualify as a moderate complexity, but does not have the ability to report for frequent dressing changes and therefore increases the risk of that encounter. Finally, we have high risk, and this would correspond to your level 5 visit, both a 99205 and a 99215. Examples provided by the CPT in this circumstance include drug therapy that requires intensive monitoring for toxicity, which I'll talk more about in the next slide, as well as decisions regarding elective major surgery for patients with identified risk factors. Decisions regarding emergency major surgery fall into this, as well as decisions regarding hospitalization. Now, again, this is a decision regarding hospitalization. This is not definitively hospitalizing a patient, but this is having a discussion about hospitalization. The final example provided by the CPT is the decision to enact a DNR order or to de-escalate care because of a poor prognosis. This is generally a lengthy conversation and involves other caregivers or family members, and therefore typically confers a high risk of morbidity and or mortality. So let's focus just for a moment on what intensive drug monitoring is. A drug that requires intensive monitoring is a therapeutic agent that has the potential to cause serious morbidity or death. Now, it's really important that the monitoring is performed for assessment of adverse effects and not for the assessment of therapeutic efficacy. Again, this is not determined necessarily based on how sick the patient's condition is, which you're treating, but instead the potential for adverse effects from that treatment. The monitoring for this drug should be what is considered standard practice for that agent, but based on patient specifics might vary. Now, the intensive monitoring can be either short-term or long-term, and long-term effective monitoring should be not less than quarterly. If it's more than quarterly, according to the AMA, that does not count as intensive monitoring. Now, this monitoring can be by a lab test, a physiologic test, or imaging, but monitoring by the history or the examination itself does not qualify. This monitoring affects the level of medical decision making in an encounter in which it's considered in the management of the patient. Again, this needs to be considered in the management of the patient that day. Real important distinction for these 2021 changes and beyond. One example provided by the AMA includes monitoring for cytopenia and the use of an anti-neoplastic agent between dose cycles, or short-term intensive monitoring of electrolytes and renal function in a patient who is undergoing diuresis. Examples that do not qualify include blood glucose monitoring during insulin therapy, even if hypoglycemia is a concern, or annual electrolytes or renal function for a patient on a diuretic, as that frequency does not meet the threshold. Real important distinction. If the guidelines state that you should check electrolytes or renal function once a year, but you have chosen to check them quarterly or more often, that still may not qualify for intensive drug management. This slide concludes our discussion about medical decision making, except for a couple slides at the end at which we put all this information together to choose the appropriate level of service. But I'm going to next talk about time, because this is really important in the fact that time alone can now be used to select the appropriate level of code for an office or other outpatient evaluation and management service code. So when it comes to time-based coding, beginning in 2021, time alone may be used to select the appropriate level of code for office and other outpatient services. This does not apply to 99211, and if you remember, 99201 is now gone, so this really applies to level 2 through level 5 visits. Now, the different categories between level 2, 3, 4, and 5 use time differently, and so it's important to review the instructions for each category. It's also important to note that unlike choosing an E&M based on medical decision making, where it's the same criteria now for a new patient versus an established patient, the criteria for selecting the amount of time still differs between new patients and established patients. Time may be used to select a code level whether or not counseling and/or coordination of care dominates that level of service. Now, the E&M guidelines for which these apply do require a face-to-face encounter with the physician or other qualified healthcare professional and the patient. If the physician or other qualified healthcare professional's time is spent in supervising clinical staff who perform the face-to-face encounter and not that healthcare provider themselves, that's when a 99211 should be used. Otherwise, levels 2 through 5 need to be chosen. For coding purposes, the time for these services is the total time on that specific date of the encounter. This does include both face-to-face and non-face-to-face time personally spent by that qualified healthcare professional on the day of that encounter. This needs to be time in activities that require the physician or other qualified healthcare professional, not time in activities performed by your clinical staff. If the patient is in your office for a prolonged period of time, but the bulk of that time is spent by your medical assistants and not you, you cannot bill for the total time spent by both you and your clinical staff. This is simply the total time that was required for you to spend on that date of service. And you should not include time on services that you report. Remember, report means bill, that you report or bill separately. So remember that time-based coding depends on both face-to-face time with patient as well as activities that do not require face-to-face time with the patient. Let's talk about some of the activities that the AMA defines that count toward time-based coding. And again, remember, this is time that you spend in clinical care for the patient on that data service, but not your assistants and other staff members. So one example is preparing to see the patient. And that can include review of your prior notes, other tests and labs are ordered, etc. Obtaining or reviewing separately obtained history. These might be hospital records, records from a prior physician or referral specialist can be included in that as well. Performing the medically appropriate exam or evaluation in the face-to-face care with the patient certainly counts. Counseling and educating the patient or their family and caregivers obviously counts. Ordering tests, medications, and procedures, whether you're in the exam room with the patient or whether you've left the exam room. Referring and communicating with other healthcare professionals, again, when not separately billed. Documenting clinical information in the health record when it's done on the same day. Independently reviewing test results that were not separately billed, and that may include communicating those results to the patient and family member. And finally, care coordination, but when not separately billed. If the patient is enrolled in a chronic care management program, then that time cannot be billed during the E&M service for that specific day. So I mentioned that the thresholds for counting time beginning in 2021 are different for established patients versus new patients, and that this is different than what counts as a level 2, 3, 4, and 5 for medical decision making for patients, because on level 4, whether it's an established patient level 4 or a new patient level 4 is the same, but time-based coding is different depending on whether or not that patient is new or established. And this chart shows the guidelines for time-based thresholds in 2021. I'm not going to read those to you. You can certainly read those off the screen, but I wanted you to be aware of the different nuances. I'll leave this up here just for a second because next I'm going to transition into talking about prolonged service codes. These are codes that would extend beyond what you would typically bill for level 5. So let's talk about those now. So prolonged service codes are a group of codes that were created and or revised that capture provider time beyond that of the highest level of evaluation and management for an outpatient visit. And most of these codes need to be billed with a primary care code. The only time we use these codes is when time is the basis for the code selection. These codes are not to be utilized if the 3 elements of medical decision making are the basis for your code selection. And the goal of these codes is to compensate healthcare professionals for the complexity of these office visits. So there's 2 codes that go into effect in 2021, and the first of these is 99417. And this is the code that applies to commercial payers. The guidelines for this code are going to be very similar to the next code, except it applies to Medicare. So this is a prolonged outpatient evaluation and management service beyond the total time of the primary care visit that has been selected using total time. And again, this requires total time with or without direct patient contact that's beyond the usual service, and this needs to be on the date of the primary service. This code is billed in 15-minute increments and listed separately and in addition to either a 99205 or a 99215. Time spent separately performing billed or reported services. Remember, reported essentially means billed. Time spent reporting separately reported services other than the E&M service is not counted toward the time to report on level 5 and prolonged service time. And again, you want to use 99417 in conjunction with 99205 and 99215, but you do not want to use it with other codes. And you do not want to use it for any duration that is less than 15 minutes beyond the time increment set for level 5s. G2212 is the Medicare code that essentially mirrors the 99417 code. Just like 99417, this is for evaluation and management services beyond the total time when the level of service is selecting using total time. This requires total time either with or without direct primary care on the date of the primary service, listed in 15-minute increments, that's billed in addition to a 99205 or 99215, and that is not reported in conjunction with other codes and not reported for any time less than 15 minutes over what is normally considered a level 5. Let's put it all together. We've gone over the diagnosis, the data, and the risk, and now we need to talk about how to use that together to select the proper E&M level. This is definitely easier this year because the criteria for a new patient and established patient is essentially the same. but I still want to review a new versus established patient because time-based billing does differ for new and established patients. So by definition, a new patient is a patient who has not received any professional services from a healthcare professional or another healthcare professional that belongs to the same specialty of the same group within the past 3 years. If they're transferring from a practitioner of the same specialty but a different group to you, then that counts. But if this is someone who has seen someone of the same specialty in your group within the last 3 years, even though they are new to you, that is not a new patient. Conversely, if this is a patient who has only ever received care from you, but who you have not cared for in the last 3 years, then that is a new patient. Conversely, an established patient is a patient who has received professional services from a qualified healthcare professional or another qualified healthcare professional of the same specialty in the same group practice within the last 3 years. If you have a neurologist affiliated with your group, as I do with mine, and that patient has only ever seen the neurologist and then comes and sees you, even though it's a member of the same group and the same tax ID maybe, it's a different specialty, and that's a new patient. Now, in the case where a healthcare professional is on call for another healthcare professional of a different group, that patient's encounter is classified as if it would have been by the professional you are on call for. So if you are taking call for another group, you're covering for a different family practitioner, and you have to have some kind of service level with one of that family practitioner's patients, but you are on call for that provider, that cannot be billed as a new patient. That's an exception to the new patient rule. Additionally, when advanced practice nurses and physician assistants are working with physicians, they are considered working in the exact same specialty and the exact same subspecialty as the physician they are working under. So really important when determining new versus established patients. Now that that's out of the way, let's talk about how to decide whether or not the patient is on level 2, 3, 4, or 5 visit with the remaining slides in this slide deck. So level 2 visits are outpatient visits which require a medically appropriate history and examination. Again, the documentation is not counted, but you still need to perform an appropriate history and/or examination, and it requires straightforward medical decision making. What does that mean? It means that the number and complexity of problems addressed is simply 1 point. There is no amount of data that is needed to be reviewed and or analyzed, and the risks and complications of morbidity or mortality for that patient management are minimal. Now, going through these office visit levels, it's really important that it's based on 2 out of 3 elements of medical decision making. It can be any 2 of the 3, but you only need 2 of the 3 between the number and complexity of problems addressed, the amount and or complexity of data reviewed and analyzed, and the risk of complications and or morbidity or mortality of patient management. You only need 2 of the 3 for both a new patient and an established patient. Level 3 visits, let's talk about those next. So this is an outpatient visit which requires, again, a medically appropriate history and an examination and a low level of medical decision making. This is where those definitions really come into play in understanding what qualifies as a self-limited problem or a stable chronic illness, or what counts as reviewing an external test, or what is a unique source really comes into play. So for a level 3, again, 2 out of 3 components need to be selected. Regarding the number and complexity of problems addressed, this could include 2 or more self-limited or minor problems, or 1 stable chronic illness, or 1 acute uncomplicated illness or injury. Regarding the amount and or complexity of data reviewed and analyzed, you need to meet the requirements of 1 of the 2 categories. Category 1 is any combination of 2 points from the following: reviewing prior external notes from each unique source. If you review notes from 2 unique sources that are external, that would count as 2 points. reviewing results of each unique test. And again, each CPT code is a unique test. So if you review a CBC and a chest x-ray, or if you review a panel 7 and a urinalysis, that would each get your combination of 2. And ordering each unique test also counts as this. Unlike levels 4 and 5, this says or for category 2 here. In levels 4 and 5, this category 2 is grouped into category 1. So I want to show you that distinction. But or requiring an assessment from an independent historian. So if you have a patient that comes in and has a stable chronic illness for which there's a low risk of morbidity, and you do not order or review any test or notes, but you get an independent history from a caregiver or spouse or parent or child, that would count as all you would need for a low level of complexity for the amount and or complexity of data to be reviewed and analyzed. And again, I just mentioned a second ago, but the risk of complications would be low. And again, the CPT manual does not define or give any examples of a low risk of morbidity. It's left up to the clinician's judgment. Now, a level 4 visit requires a moderate level of medical decision making, again, based on 2 of the 3 components. Now, let's give some examples for each one of these categories. So for the number and complexity of problems addressed, this can include simply 1 or more chronic illnesses with an exacerbation, progression, or side effect of treatment, or 2 or more stable chronic illnesses, or 1 undiagnosed new problem with uncertain prognosis, or an acute illness with systemic symptoms, or an acute complicated injury. The amount and or complexity of data to be reviewed and analyzed, though, does change a little bit. In order to achieve a moderate level in this category, you need to get 3 points in category 1, which I've already reviewed, or you need to independently interpret test results. And again, we've already defined what that means. Or you need to document that you've discussed the management or test interpretation with an external healthcare provider. And in order to get a moderate level, you need to meet the criteria for 1 out of 3 of these 3 categories. When it comes to the level of risk, again, this needs to be a moderate level of risk. I've already gone over what that means, but the example I'm going to really highlight here that will be applicable to most of you would be prescription drug management. Finally, to bill a level 5 visit, again, you only need to get 2 of the 3 components or elements of medical decision making to be met, and they need to be of a high complexity. And high complexity, under the number and complexity of problems addressed, would be 1 or more chronic illnesses with severe exacerbation, progression, or side effects of treatment, or 1 acute or chronic illness or injury that poses a threat to life or bodily function. Again, these are very clearly defined by the AMA, and which is why I spent so much time reviewing these definitions. This reliance on medical decision making, which hopefully will decrease provider burden, absolutely does require that healthcare providers really understand what each of these definitions mean. When it comes to the amount and or complexity of data that's to be reviewed and analyzed, in this case, you need to meet 2 out of 3 categories. Again, category 1 includes test and documents ordered and or reviewed, as well as independent historians. Category 2 is the independent interpretation of test results. Again, these are not separately billed. Or category 3, which is discussion of management or test interpretation with an external provider. 2 of these 3 need to be met if you're going to count the amount and or complexity of data as one of the 2 components of medical decision making to determine the level of service. And finally, for the risk, you need to have a high risk of morbidity from additional diagnostic testing or treatment, and I've given these examples in a previous slide. And just to review one more time, if you want to bill based on time, you can do that based on time alone, as long as it's spent on that same day of service and done by you, whether it's in face-to-face interaction with the patient or not. And that is the end of this presentation. Thank you so much for your attention and for your desire to learn more about these billing and coding changes. I look forward to any feedbacks. You can leave things in the comment. I'll be posting more videos like this, talking about other coding and documentation, so please like and subscribe this video. Thank you.